Welcome to our live webinar titled Secondary MDS and AML in Women After Chemotherapy. Thank you for joining us. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I'd like to recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda Oncology, and also the generous support of patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your questions all at the same time. Second, please do not share any private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Kathleen Moore. She is an associate professor in the section of Gynecological Oncology and serves as the director of the Oklahoma TSET Phase I Clinical Trials Program, the state's only Phase I clinical trials program. She is the Jim and Christy Everest Endowed Chair in Cancer Research, as well as the director of the Gynecological Oncology Fellowship Program. She also serves as the associate director of the Clinical Research and medical director of the Clinical Trials Office for the Stephenson Cancer Center. With that said, welcome, Dr. Moore, and thank you for joining us today.
Well, thank you so much for having me. It's definitely my pleasure to speak to you today. I love speaking with patients and families. And this was actually a fun talk for me to put together. This is actually a brand new deck for me. So you guys are a little bit my guinea pigs. So give some feedback. And I appreciate the kind introduction. I am, just so you can I can set the stage. I am trained as a gynecologic oncologist. And I run mainly early phase clinical trials, although I do late phase as well. And my career has encompassed a lot of things, but has been centered on development of what are called PARP inhibitors, which we'll discuss later in the talk, which are amazing. PARP inhibitors in a number of disease sites, but also we think may increase the risk of secondary myeloid neoplasms like AML or MDS. And so I'm unfortunately becoming a little bit more of a knowledge, at least a space expert in those secondary malignancies. So I'm going to talk about that today, kind of mainly as an overview when we think about these secondary myeloid neoplasms, sort of what are risk factors and maybe what we can do about them. So objectives say really to define what we're talking about when we talk about secondary AML or MDS, which is a really gross oversimplification of the number of diagnoses that fall under these two terms. So really what we're going to talk about is treatment-related AML MDS. We're going to talk about the diagnosis of this and how treatments are considered. I'm going to give you a broad overview of prevalence, like how often do we see treatment-related AML or MDS among people who are diagnosed with other malignancies, and what are the risk factors for developing these secondary malignancies. And then we'll talk specifically about PARP inhibitors and why this is becoming a more known issue kind of outside of hematology circles as we're seeing more of it kind of in solid tumors as well and having to deal with it more frequently. So let's start with secondary AML. What is it? So in broad strokes, you talk about de novo kind of myeloid neoplasms, which is myelodysplastic syndrome, AML and others. Those are the hematologic cancers and precancers that start kind of out of nowhere. No precursor exposure that we know of anyway, that led to that condition. A secondary myeloid neoplasm, or secondary AML is on the slide, arises because of some predisposing event. Now, most commonly, and what you can see here, so here's de novo. So most AML is de novo, doesn't have a preceding risk factor. If it does have a preceding risk factor, most commonly for secondary AML, it's preceding myelodysplastic syndrome, preceding MDS, de novo MDS. So that's the most common thing you see. You see that here in the red and yellow. You can get AML from prior MDS or AML from prior, these are proliferative neoplasms. And then in this purple is where you see the group that we're talking about today. So these are myeloid neoplasms that start following an exposure to a cytotoxic, either chemotherapy or radiation therapy. So someone had a prior cancer, and this actually includes not just cancers. There's folks that have autoimmune disorders that are on therapies that help them with those autoimmune disorders, but some of those therapies also predispose to these secondary myeloid neoplasms. So it's not just a function of prior cancer treatment, there's other disorders that the treatments place patients at risk for this, but we're just gonna mainly focus on preceding cancer for this talk today. So treatment-related AML, patients have some history of treatment with a DNA damaging agent, either chemo or radiation, and they can get treatment-related AML, treatment-related myelodysplastic disorder, or what we call treatment-related myelodysplastic or myeloproliferative neoplasms, which I'm not going to talk too much about today just to simplify. These look very similar in many respects, in some ways different, but in many respects they can look very similar to myeloid neoplasms that arise without a preceding exposure to chemotherapy or radiation, but they do have some distinguishing features and unfortunately can have poorer responses to therapy. And so they are a group, it's small, but it is a group that if we can prevent these, we want to. So the causes. So when we think about what causes a treatment-related myeloid neoplasm, mainly just focusing on prior cancers, there's sort of four main categories of treatments that place patients at risk. And you can see them listed here. And these are basically anti-cancer therapies. Alkylating agents are a class of chemotherapy. They include older drugs like melphalan and cyclophosphamide, which we still use. But they also include carboplatin and cisplatin. And I'm going to talk more about the platinums a little bit, actually not too many slides from now, because these are on the rise. And these are kind of a part of the family of alkylating agents. But they are definitely drugs that place patients at risk, so things we have to keep track of. Radiation therapy is if it encompasses a large percentage of bone marrow area, can place patients at risk. So pelvic radiation is one of those, or mantle radiation is one of those. And often we give chemotherapy with radiation, so it's kind of a double hit. There's something called topoisomerase 2 inhibitors, things like etoposide, and I haven't read here the key ones. These are drugs we still use in a lot of tumors, and I'm going to show you this. Doxorubicin, it's called an anthracycline. Doxorubicin is the class of drug. You may know it as adriamycin, or daunorubicin is commonly used. Doxorubicin is a drug called pegylated liposomal doxorubicin, we call Doxil. So very commonly used drugs, very common. They fit into this group. And then there's other. There's always another, right? So really others, like any other chemotherapy, there's some associated risk, although less. So the taxanes, paclitaxel, docetaxel. There's some data for growth factors. So pegfilgrastim or filgrastim, we call them Neulasta or Neupogen. There's others. There was some sense that maybe the use of those may contribute to the risk of treatment-related myeloid neoplasms, but that's really not been proven. And I think that association is a little bit unstable. So I definitely wouldn't refuse growth factors because of that risk. It looks, at least from the breast cancer literature, which is a large number of women, does not look to be a stable association. It's just probably related more to the chemotherapy. So when we think about this, there's sort of specific types of presentation and treatment-associated myeloid neoplasms you see with each of these groups. So when you're thinking about what happens after alkylating agents or radiation, and I just put a little picture up of kind of how alkylating agents work, they damage DNA, and that's one of the requirements for causing these secondary or treatment-related neoplasms. But if you're gonna get a treatment-related myeloid neoplasm following an alkylating agent or following radiation, it typically presents 5 to 7 years after treatment. So a little bit longer latency until those developed. What you'll see is patients will present oftentimes with, an incidental finding of what we call pancytopenia. So they may get a blood test for some reason at their PCP and their red cells are down, that's called anemia. Their white counts down, that's called neutropenia, and their platelets are down, that's called thrombocytopenia. So you'll see this trilineage, so each blood lineage dysplasia, so you'll see atypical cells and decreased cells. And then you'll find these chromosomal abnormalities that are pretty characteristic. That's deletion of chromosome 5 or 17, or you can see these monosomies as well. And these are things you see on the bone marrow biopsy and by flow cytometry when we're really working these up. So there are some characteristic findings that kind of tell us this is definitely a treatment-related myeloid neoplasm, although sometimes you can't be certain, but this leads to that diagnosis. And then for the topoisomerase inhibitors, and again, these are the anthracyclines, doxorubicin, daunorubicin, very commonly used drugs in a lot of cancers, especially breast cancer. Again, just a little picture of how these work. And again, they act through causing DNA damage that can't be repaired, which makes them good chemotherapy agents, but it's one of the things that can induce enough DNA damage to lead to these downstream secondary cancers. The latency here is shorter. So patients who, for whatever reason, are at risk for these treatment-related myeloid neoplasias that get exposed to an anthracycline, for example, the latency is only 1 to 3 years. So you can see these quite a bit earlier. They typically present as AML rather than myelodysplastic syndrome. So it's unusual to have an MDS. These are they present as a leukemia, and they have distinct cytogenetic alterations. I showed you the mutations related to alkylating agents. These look different. And so it's a way just to distinguish. It doesn't really change how we treat them or prognosis. It just kind of tells us maybe why it happened. And so that's sort of the next question. Why did this happen? That's what everyone asks. Why did this happen to me? And the truth is that we don't really know for sure. If we knew for sure, there might be some things we could do to prevent it, but there are risk factors that may predispose folks. So certainly having a kind of a baseline germline, meaning you were born with it, a mutation in DNA damage sensing repair genes. So the classic one here is BRCA. Some people call it BRCA, BRCA1 or 2. So this is a tumor suppressor gene that that anyone, male or female, can inherit from a patient or from a parent, and it predisposes to development of a number of solid tumors, actually. Breast cancer, ovary cancer most commonly, pancreas cancer, prostate cancer also associated. So predisposes, but it also makes them very susceptible to response to chemotherapy, so that's a good thing. But there may be a signal, and I'll show you that at the end of the talk, that this group of patients may be more at risk for these treatment-related malignancies, kind of more to come as we follow them. And then germline loss of TP53, which is called Li-Fraumeni syndrome, which is pretty rare and predisposes patients to a lot of cancers. Also, if you treat those cancers, may predispose them for secondary malignancies down the road. So those are two kind of genetic predisposition factors that may play a role. Certainly just exposure to chemotherapy places you at risk. Obviously, we're talking about treatment-related myeloid neoplasia, but excessive chemotherapy really can place patients at risk. So it may not be like that, you may not be able to know it was the alkylating agent or the topoisomerase II inhibitor. It's just sort of the cumulative effect of years of DNA damaging therapy on someone's bone marrow can predispose them to these secondary malignancies. And this is really, at least in my world in ovarian cancer, where our patients fortunately can live for many years, unfortunately with disease and with continued treatment. And we used to just continuously treat them. Now I think we do a lot more treatment breaks and non-cytotoxics for many reasons, one of which is to avoid these secondary malignancies, but for other reasons as well. But you have patients, and I'm going to share a case with you later, that will have 7, 8, and 9 lines of chemotherapy, and who knows which chemotherapy kind of broke the camel's back, but you can develop these secondary malignancies just by beating the bone marrow up for so many years. So excessive treatment, many, many lines of therapy can do it. And then there's this very interesting phenomena or finding called CHIP. And so CHIP stands for clonal hematopoiesis of indeterminate potential. So this is, these are mutations that exist within kind of our stem cells. So not in the tumor, and not necessarily something that you know you're born with, but they're mutations that exist within kind of the bone marrow, basically. And they're listed here that may predispose patients who have cancer. They don't necessarily predispose to a cancer, but in patients who have cancer and then get chemotherapy, it may place them at higher risk for developing these treatment-related myeloid neoplasms. So the prevalence of this is pretty low, about 10% thus far, although I think that there's still a lot of interest in research being done, and how you even identify this has really been from research settings thus far. There's no commercial test for this. It seems to be more associated with age, so maybe something you collect over time with sort of just, you know, we age and we make more mutations. So you do see a higher prevalence of it in patients over 80 rather than patients 70 to 80. You can see it in younger patients though. And it does really seem to be associated with development of these hematologic malignancies, secondary malignancies. So you see this sort of curve here of all the patients who do and don't have CHIP. And what's interesting about this is just a study that was presented, and this is from a really great talk that was given by Dr. Lancet at ASCO a couple years ago now. They looked at patients who developed treatment-related AML in this case, and then they looked at patients who hadn't and looked to see kind of the development of, or they looked to see of all the patients that had this CHIP mutation who didn't develop these secondary malignancies. And so if you had it, it was like 62 and 71% versus about 30% amongst the controls. So not everybody that they have these CHIP mutations developed a secondary malignancy, but it was much more likely to be found in patients who did. The other interesting thing is that the, and you can see this in the lower graph that I hope you can see, it's a little bit small, I know, but the mutations that are a CHIP mutation, like TET2 is one of the more common ones, aren't really the ones that are like the driver mutation for developing the cancer. So there's something that happens because of those mutations in the microenvironment that, or just maybe enough kind of oomph in a progenitor cell to get it going and then develop mutations that would lead to the AML. So there's another step in here that we don't quite have fully elucidated yet that links these CHIP mutations to development of secondary malignancies. But this is a really interesting sort of line of research that someday may help us identify folks who are at greatest risk. But the question is, if you found this, what do you do with it in light of potentially selecting or not selecting a therapy that had a survival advantage, for example, for a patient, or a curative advantage for a patient with a still relatively low likelihood of developing a secondary malignancy. So this may be interesting, but it may like add so much uncertainty to decision-making and unnecessary anxiety that maybe one of those things we don't want to know. but it is interesting from a scientific standpoint in terms of really trying to figure out who's at risk. So I'm going to share kind of the overall prevalence of these treatment-related malignancies across some disease types. We don't have enough time to discuss them all. But just to couch it a little bit, when we give these prevalences, meaning how often do you see this, they come from registry data, like big databases, SEER, billing databases that have to look at a lot of patients because they're so infrequent, a lot of patients with cancer over time, because remember I told you with alkylating agents, it's 5 to 7 years. So you have to look way back, probably 10 years or more, to get a cohort of patients who are treated for a particular cancer, all the cancers, and then have been followed long enough to be at risk for these secondary malignancies, and then look back and see what was causal. Well, what happens over time is that we change the standard of care, we change therapies. So, what we see on this paper today, and these papers I'm going to show you are all very recent, but they're based on treatments that are like a decade old. So we have to take it a little bit with a grain of salt and think about how therapies change and whether or not the risks go up or down. And I'll show you some examples of that. But this sort of color chart shows you, and I know it's tiny, but I highlighted some of the ones because I knew we were talking about women's cancers. So what this shows you is trends over time for use of various chemotherapies. So what's in red is carboplatin, platinums, so carboplatin, cisplatin, so alkylating agents. And what is in the orange that you can see are platinums with anthracycline. So 2 of the risk drugs are in orange. And then green is just alkylating agents with or without an anthracycline. So what I want you to see is that, at least for the cancers that I'm going to focus on today, for like ovary and fallopian tube, which are basically the same, you should know that, carboplatins have been the standard of care for decades. And so there's no change in carboplatin, and I'm going to show you there's been no change in the risk of AML or MDS, secondary AML or MDS in this population over time. But look at uterus, where there has been a precipitous increase in the use of platinums over time. And that just came from research that was published kind of 2010 timeframe. Same with cervical cancer. We use way more platinums now, although it's a rare tumor, so it's hard to see that increase. And then vulvar and vaginal cancers, where in the past, like when I was a fellow, which I guess is getting longer and longer now, there was no chemo approved. If you had vulvar cancer, vaginal cancer, like we couldn't use it. No one would pay for it. And now we use platinums all the time. And so these 3 tumors, you've seen platinums go up, and also breast cancer. And that's very recent, especially in triple negative breast, BRCA, you'll see more platinum use. And so does more platinum use correlate with an increased risk of treatment-related myeloid neoplasms? We probably haven't followed folks enough yet, but there's some interesting trends. So this is all from the same paper. It's a really interesting paper in JAMA just a couple years ago, and I've highlighted here the group of breast and the gynecologic cancers, just because that's my world, so I'm going to focus on that. But there are some suggested increases, a little bit, in the prevalence of treatment-related myeloid neoplasms for breast and cervix and uterus and vagina, all places where we saw an increased use of platinum. So that's kind of interesting, but you can still see that and I know this is small, I should have done a blow up of this, but for example, if you look at uterus, the SIR, which is the incidence rate over incident rate that you see over what's expected. So if it's 1, that means there's no increased risk in that disease type. Anything over 1 gives you a sense of how many more cases you're seeing over what's expected, like in the general population. So it's 3, so it's pretty low, but it's still better, more than 1. And then it goes to 6.2 in this latter time period with the increased use of platinum. Still low, but that's interesting. That's an interesting change We also use radiation in uterine cancer, so it may be a combination of the two. It's hard to make any big causal statements, but it is something to watch. You can see the same thing in cervical cancer, for example, where it's 3.3 to 5.7 with increased use of platinum. So I don't think that we're going to see this explosion of treatment-related myeloid neoplasms with the increased use of platinums. And if you look back at this, there's a few disease types outside of women's cancers where you see increases in platinum use as well. So, so it's maybe something, a little nudge we see across the board and something we need to track with time. But we don't see an increase in ovarian cancer, at least in this time period. So this is 2000 to 2006 in the first column, and then the second one is 2007 to 2013. As I said, platinums have been the standard of care for decades, so you wouldn't expect to see a difference. But this is where, you know, these registry data are great, but you won't be able to do another data cut for many years until you get enough kind of follow up, another 7 years. So maybe we'll get some now, 2020. But we have PARP inhibitors, as I'm going to talk about. PARP inhibitors may change this, this incidence rate, this SIR for ovary cancer, because now we have added something and most women are getting it now, and we'll talk about that. So we may see a bump, and that's something we have to track with time and changes in therapy. But at least based at this time point, there wasn't a change. And so this is just gives you an idea, because I know this is anxiety provoking, like, all these secondary malignancies, so high risk, but it's still really low prevalence. It's important if you get it, because it can be a really, especially for ovarian cancer, patients with ovarian cancer can be a really terrible thing. But we'll talk about treatments in a minute, but it's very low risk. And so when you weigh the risks of benefits of therapy versus I'm worried about treatment-related myeloid neoplasm, so I'm not going to take therapy, like benefit risk completely separate. But we still need to pay attention to this. So this gives you the 10-year cumulative incidences of treatment-related myeloid neoplasms amongst women treated for women's, I call them women's cancers, breast and all the gynecologic, except for fallopian tube, which is interesting, and it may just be a fluke. Fallopian tube's really small, and it's really difficult to diagnose apart from ovary, because oftentimes women present with advanced disease, and how do you know it started in the fallopian tube and not the ovary? So it may just be a fluke, but fallopian tube cancer is more associated, you see it more in women with BRCA-associated cancers, and BRCA is a risk factor, so it might be real. So I think we have to look at that a little bit more. It's not tremendously higher than 1.22%. The rest are less and significantly less than 1% cumulative incidence of treatment-related myeloid neoplasms. So really uncommon. So that's kind of the incidence, and we'll go a little bit more into breast and ovary in a moment. How do patients present? They really don't present any differently than de novo AML or MDS. So they may have no symptoms and it's caught on a lab, or they may present with symptoms related to the changes in their bone marrow kind of line. So they may have weakness if they're anemic, they may have easy bruising or like nosebleeds, or you know, if they brush their teeth, a lot more bleeding because their platelets are down. So they may have these subtle signs that we see, but it just may come from a blood test. So if someone is suspected of having any kind of myeloid neoplasm, we work them up the same. So you get a CBC, a complete blood count, and you're going to see one of two things. You may see all the cell lines decrease, like we talked about previously, or in someone that may be having a blast or impending blast crisis, you may see what's called a leukocytosis, so a lot of white counts. So anything over 50,000, for example, is sort of a little bit of an emergency that we have to deal with. So we do that, and if it's normal, you know, it's not a myeloid neoplasm. If there's something there, then we do what's called a blood smear, a peripheral smear. And you do get quite a bit of information from that. So I'm just going to show you some examples, and I mislabeled this, so I apologize. These are red blood cells. And so what I'm trying to show here, you know, when you have anemia related to myeloid neoplasms, these red cells, the nuclei, which are those purple things in the middle, like you see all the other normal red cells don't have this really bizarre, they shouldn't have a nuclei when they're mature, like it's gone. That's an immature red cell. So these neoplastic red cells have these bizarre nuclei that identify them as neoplastic. And then if you look at the white cells, these are neutrophils. And so you'll see these bilobed, two-lobe nuclei with this little kind of attaching string between them. That's called a pseudo-Pelger-Hewitt anomaly. Pseudo because there's something called Pelger-Hewitt anomaly that's like an autoimmune issue. So it looks like that, but it's in AML. And so this is one of the pathognomonic findings that we see on a blood smear that makes you worry. So if you see anything like this, and then you kind of get, you'll graduate up to a bone marrow biopsy, but we also check chemistries, which are your salts, because someone with myelodysplastic syndrome, you don't see this too much, but with acute myelogenous leukemia or any of the subtypes, those leukemic cells, I told you they could be really high. Those really proliferating leukemic cells can lead to problems. Like you can get really too acidy because of high uric acid or high lactic acid. And we got to take care of that before you get sick. You can get your phosphorus, like your kidneys can kind of get out of whack. So your phosphorus can get really high. Potassium can be abnormal. Calcium can be abnormal. And if those things happen, then patients can get really constipated or confused, or they can have arrhythmias. And so if we see any of that, which is sort of correlated with what we call tumor lysis syndrome, where you just have so much proliferation of cells and they start to break down and release all of these toxins, and patients can get really sick. That's, you know, in the AML setting, for those of you that have been diagnosed. And I see this in phase I because we have a lot of AML studies open. Like we admit those patients right away and get them started on treatment because they're about to get sick. So we always check the chemistries and make sure that we don't have an impending emergency. And then the bone marrow biopsy is key. So it should include a number of things that are done, and sometimes frustratingly take many days to get an answer. But you do microscopy, which is what you see here, and these are what blasts look like. So these are immature white cells that you'll see in AML. So this is when you see circulating blasts, this is what you see. So we do immunohistochemical studies, which basically means we look at the slide and we look for proteins on the surface of the cancer cells, and it will give us sometimes some more clear identification of what type of AML it is, because there are different therapies that you use for different types. Immunophenotyping is really important, although for treatment-related myeloid neoplasms, there's not a specific immunophenotype that says this is treatment-related or not, but for all the other myeloid neoplasms, they do immunophenotyping. And I told you all of the kind of genetic findings that identify a patient as having certain types of treatment-related myeloid neoplasms, but also there's a number of cytogenetic abnormalities that just identify different sorts of AML. And so they run all that as well. And it can take sometimes a week or so to get all of that back, so you really know what you're treating. And then you make the diagnosis. So to have a diagnosis of treatment-related AML requires that you have a prior treatment with a DNA damaging therapy, either chemo or radiation, that you've done a bone marrow biopsy, and that 20% of the bone marrow or more, or greater than 20%, I'm sorry, has infiltration of blasts. The leukemic cells need to be myeloid in origin, not lymphocytic. And then these are all the, I was saying the cytogenetic tests, these are all the things you look for to diagnose AML. You know, and in particular, and I'll give you this case in a bit, number 3, you look for acute promyelocytic leukemia, or APL. That's a completely different treatment than the 7 and 3 that we do for regular AML. So this is really important to get it right from the beginning. For treatment-related myelodysplastic syndrome, again, same thing. You have to have a prior history of being treated with something that would cause it. On the peripheral smear or bone marrow, you have evidence of significant dysplasia, which are atypical cells, but your blast count is less than 20% or less. So that's one of the key distinguishing features between AML and MDS. So for treatment, when you're thinking about how you're going to treat somebody, this is really complex. And as I said, I'm a gynecologic oncologist who knows just a little too much about, unfortunately, about myeloid neoplasms these days. So you really, number one, need an expert in hematologic malignancies to assess every patient, 100% agree. But these are the basics. I talked to my, my heme partner about how he thinks about patients. So number one is you assess for medical fitness. And it's not just, you know, when I look at somebody who I'm going to operate on or give chemotherapy, I'm like, you look good. Performance status, pretty good, we're good. This is a much more stringent set of scales that are used to really assess someone's medical fitness to undergo intensive therapy or less intensive therapy. And so really identifying the fitness of our patients is critical in selecting the right therapy for them, because they can be tough. And so you really have to assess medical fitness for not only the chemo, but also evaluating for the potential for transplant. So those are kind of the things that the medical oncologists who specialize in transplant and hematologic malignancies are thinking about from the beginning. Is this somebody that can get to transplant? Because that's the way you cure, is you get them to transplant. Treatment-related myeloid neoplasias can't be treated with chemo alone. You got to get them to transplant. So is that a possibility? Yes or no is one of the key things to think about in this setting. And then you have to assign a prognostic category to the cancer based on, again, those cytogenetic and molecular features. So that's separate from the fitness of the patient to undergo therapy. There are features of the cancer that says this is a favorable kind of in the middle, which you usually give benefit of the doubt if someone's fit, or an unfavorable prognostic cancer. So those are the things, the basic things that you think about. And so when you what are the cytogenetic features that you're looking for? There's many, but for treatment-related myeloid neoplasias, things that make us say this is an unfavorable prognosis are those abnormalities on chromosomes 5 and 7, or if you find mutations in TP53, which can be in up to 50% of treatment-related myeloid neoplasms and can be an adverse prognostic feature. And that's why I have that little figure in the upper right-hand side of your screen. This is from a nice paper in Blood. And these are all treatment-related myeloid neoplasms. It just kind of tells you that it's not one size fits all. The dark gray is TP53 mutated. And so it looks, you know, more common in kind of the 50 to 70 age group, but can be up to 50%. And then you may have other secondary types of findings in these tumors. And some of them look just like de novo, you know, even though they're treatment related, they just have features that look just like de novo AML. So they don't all look the same at all. So this is just a nice, I thought, figure that reflects that you really have to individualize how you think. This is true of all cancers. You have to individualize how you think about treatment for these really rare and complex cancers, patient by patient. Like there's not a book on this. I know because I look for it. So, so that's sort of what one of the things we think about. And then if you think a patient has a favorable or even an intermediate prognosis, you're thinking about transplant. So you're going to be going for intensive remission induction therapy with a plan to get to transplant. And you base that really on the features I just talked about. Age doesn't play a huge role. Like it's not like, oh, you're over 80, so we're not going to give you intensive therapy. It does play a role in the dosing, but it doesn't play a role in just dismissing somebody from consideration of aggressive treatment, which I think is nice. That's said repeatedly in the literature. There's quite a few ways to skin a cat. And again, this is very individualized, but sort of the two criteria or two treatments that people think about are 7+3, which is cytarabine and anthracyclines, or basically the same thing, but in a liposomal form. So liposomes kind of increase the length of time a drug stays in your body, and ideally gets a higher dose to the tumors. And so this is the Vixios product, which I'm going to just give you 2 slides on in a minute because it's interesting. But that's what you're thinking about mainly for induction therapy to get someone to transplant. And just because someone has a treatment-related myeloid neoplasm, in particular treatment-related AML, doesn't mean that a physician's not going to try and treat them for cure and try and get them to transplant. So that's important to say up front. You look at the literature and there's lots of discussion about these do have a poor prognosis, and they do, and that is unfortunate. And I'll give some examples of sort of, at least in the gynecologic world, how we think about it. But in someone whose preceding disease is cured, who now presents with this, and they are fit, and it has a favorable or even unfavorable, but they're fit, you may have a situation where someone's still trying to get someone into remission and get to transplant. So these are incredibly individualized decisions made by experts all the time, not by GYN oncologists. Unfavorable prognosis. So if you really have somebody that has an unfavorable prognosis tumor, again, it's not a clear consensus. You may try for cure, or if you have someone that's just really frail or their preceding disease isn't under good control, which is what happens in my world a lot, then it's truly individualized goals of care kind of discussion. You may try some less intensive therapies, though, if you think you have either their disease is there and it's under control and can kind of sit, or if you have a planned treatment that if you can get their secondary myeloid neoplasm under control, then you have something for their primary disease that should work. You can work with the medical oncology, the hematologic oncology specialists to tailor therapies that can treat both or do things in sequence. And I've certainly done that. Again, there's no book on that. It's individualized based on the patient's desires, fitness, and expectations of benefit. But there are a number of less intensive therapies that you can do to try and ameliorate symptoms or get one thing under control so you can treat another. And this is just a list of them with quite a bit of data. So I wanted to just mention the Vyxeos, which is this liposomal cytarabine and daunorubicin. So it's an anthracycline and cytarabine, very standard drugs, but it's in this cool little liposome. And this is the data that was presented. It's FDA approved and is one of the standards of care. And it was called out again on this really great talk that Dr. Lancet gave a few years ago, because it did include a fairly robust number of patients with treatment-related AML. And they're not excluded from a lot of the trials, but there's just not many of them on. So it's hard to sort of make statements about how they do in a particular therapy. But this one actually had enough on that you could make some statements that it did seem to improve outcomes. And so it is considered one of the, you do 7+3 or this, this liposomal therapy with some robust data in treatment-related AML, which is always nice when you actually have data for the, as much as you can, the specific situation that you're treating. So that's the only reason I wanted to show that, is that this trial does have that particular population that we're talking about included in enough numbers to make a statement. But it's an FDA-approved option for intensive therapy. So that's sort of the background. I just want to talk a little bit more about the particular women's cancers. And so I wanted to put up a case. So this is a woman with breast cancer with a BRCA1 associated breast cancer, triple negative breast, who was treated very appropriately with 4 cycles of an anthracycline-based chemo, followed by paclitaxel and radiation. And she completed that in 2017. In 2018, she presented for surveillance. And like I was saying, she's fine, but her platelets were, 85. Well, that's unusual. Like, why would your platelets be 85? So they work it up and a biopsy is obtained. And she actually has a pre-B ALL, which you can see. You can see kind of any of these hematologic myeloid neoplasms post these DNA damaging therapies. And it definitely looked treatment related. They did a full work of it, and it had none of the sort of de novo findings of ALL that you would expect. So this really was a different looking disease consistent with a treatment related myeloid neoplasm. And so this is a case where you have someone whose primary disease is cured, under control, and now presents with a secondary or a treatment-related myeloid neoplasm, in this case, a cancer. And so this is a candidate, young woman, very fit, where you would go for it and do induction therapy, which is what they did. They achieved a remission and then tried to do some consolidation. But unfortunately, at the end of consolidation, she was found to still have blasts. And so was in progression and no longer a transplant candidate. And so the likelihood of cure here is gone. And again, these tumors can have a poorer prognosis than we normally see, but it doesn't mean we don't try to go for cure when it makes sense. And then this is sort of the poster child in whom it would have made sense. But what is the risk in breast cancer? Like, is this common? Do we see this all the time or not? It's really not. So this is another nice paper that looks particularly at breast and ovarian cancer, different database. And I'm just going to highlight here the incidence rate ratio, which is based on the chemotherapy, duration of time the chemotherapy was given, is between 2.6 and 1.8. So this is, again, an incidence of what you see over what you expect. And what you expect is 0.3%. So it's 2.6 to 1.8 times that. So still very low risk, but it's there, and it is higher than baseline. So we have to acknowledge that. Again, back to what I said in the beginning, is that it's important to note that this data reflects kind of regimens that may be less popular now. And this little figure kind of shows that. In the blue on the top, that's anthracycline plus taxanes in the dark blue. And you can see that we still use it commonly, but the rate that we use it, or the commonality, is coming down. It started coming down about 2007, and taxanes and cyclophosphamide started increasing at that time. So how will that impact the rate? Cyclophosphamide is an alkylating agent. So you've traded an anthracycline for an alkylating agent. Which one is higher risk? We have to see how that might impact the rates. And we may see that, now, 2020, we may have the data, but all this sort of prevalence rate, you do have to keep this in mind, that it reflects an old standard of care, which may not be relevant anymore. Be that it may, we do see increases, as I just said, in both AML, which is what you see in the A graph, and MDS, which is what's in the B graph. So what A shows you is that in patients with a history of breast cancer, any anthracycline, which is adriamycin or doxorubicin, people use different names, any anthracycline containing regimen increases the risk of AML. And you see that in the top two lines of this graph in blue and red. And any chemotherapy, regardless of mechanism of action, increases the risk of myelodysplastic syndrome, which you can see in B. There's no real clear separation between the bars saying one causes more than the others. They all increase the risk. So that looks scary because you have these increasing bars. But when you absolutely look at the cumulative incidences, the risk is still really small. So here's I'm just going to highlight the 5-year incidence, but I could easily highlight 8-year. What you see with no history of chemo. So say someone had breast cancer and had a lumpectomy and didn't need any chemo. So that's your baseline reference. And the percentage is 0.3. So 0.3% risk of developing what would probably be called a de novo AML or MDS later. And that increases to at greatest 0.61 anthracyclines plus taxanes. So anywhere between 0.53 and 0.61 with anthracyclines. So less than a percentage point for 5-year cumulative index for AML. And if you go out to 8 years, it's still less than 1%. If you look at MDS, which is a broader category, so the rates are going to be higher, you see it's between 1.2 and 1.7% as compared to reference range of 0.88%. So it's like your baseline risk of having some kind of myeloid neoplasm, or in this case, in myelodysplastic syndrome, 0.88%. That can increase to 1.2 or 1.7% if you've had a history of anthracyclines. So definitely an increase associated with the chemo, but the rates are still remarkably low. So here's ovarian cancer. This is unfortunately, I have several patients like this. So she's 38 when she's diagnosed in 2008. A BRCA-associated cancer, very strong pedigree, was treated, gosh, except for one of these regimens, just like I treat patients. Got paclitaxel carboplatin first, got docetaxel and carboplatin when she recurred, then got cisplatin and gemcitabine when she recurred again, and then got pegylated liposomal doxorubicin, so an anthracycline, and paclitaxel. I think that's a weird regimen, but I'm not judging. For her third recurrence, And then in 2015, so she's been treated now for 7 years, four chemotherapy regimens. She presents with brain metastases, which are more common amongst our BRCA-associated cancers, and gets chemotherapy for that, platinum-based chemotherapy, but has to be stopped because her bone marrow just can't tolerate it. And they look at the peripheral smear and see a lot of abnormal promyelocytes, and then does a bone marrow, and she has treatment-related AML, in this case, acute promyelocytic leukemia, in October of 2018. So I told you about the 7+3 and the vitreous. This gets a completely different regimen, which is why it's important to really know what you're treating. And she's treated very appropriately with ATRA and ATO, gets a molecular remission, actually. And then consolidation is still in remission. This is someone where transplant is not likely to be considered. I mean, we've had 5 recurrences of ovarian cancer. So this is a pretty aggressive approach in this particular setting, but I'll tell you, she's still sensitive to platinum, and she has not set a PARP yet, and the PARPs were just approved in 2017. So being aggressive and trying to get this under control so you could consider treating her cancer some more, you may buy her more time. So this is probably pretty aggressive in this setting, but you have to take it in the context of expected response and fitness. But unfortunately, even though her APL was in remission, during the time to treat that, her ovarian cancer got out of control and she passed away from ovarian cancer. So you have these competing risks in the ovarian cancer space when these occur. And this is kind of an example of that, and frustrating. Risk for ovarian cancer is here. It's similar to breast, about 2.27, 2.1. So pretty low, but it's there. And again, this predates us using PARP inhibitors. So that's how I just want to end my talk is kind of what's next and what are we seeing with use of PARP inhibitors. So just to remind you, we've been talking about drugs that target how DNA repairs itself. And this is just a cartoon of that process. And the important thing to focus on is on the left-hand side where you have homologous recombination. That's what HR stands for. That's the process by which cells repair double-strand DNA breaks. Those are the most lethal type. And they're induced by things like carboplatin and other drugs. So if your tumor is really good at homologous recombination, that means it can just fix whatever damage the chemo throws at it, and it will live like a roach. If tumors are deficient in some of the proteins that are responsible for homologous recombination, like BRCA and others, then they're very susceptible to chemo and inhibition of other parts of that process. One key part is the PARP protein, poly-ADP ribose polymerase. So this is a cartoon of that. So PARP, the protein, which is in purple, finds sites of DNA breaks and binds to it to fix it. So if you have a PARP inhibitor, which is in orange, it comes and sticks to it. And so when that replication fork comes down to fix the DNA, you basically have stuck a piece of gum on the DNA and the replication fork can't get by, and that creates double-strand breaks. And if you have a tumor, again, that's good at fixing its double-strand breaks, it's just gonna fix them and move on, and the PARP inhibitor doesn't work. But if you have a tumor that's deficient in how it fixes its double-strand breaks because it has lost BRCA or any number of other proteins, then it can't fix that and the cell will die. And so you take a cell that's already vulnerable and you take out one of its key proteins, PARP, and you can cause cell death. So these are very exciting because when you think about ovarian cancer in this pie chart, basically everything on the right-hand side of the pie chart, all the green are the incidence of loss of BRCA in one way or the other. So it's about 25% of patients. And then the blue is other ways you just lose the ability to fix double-strand breaks. So, and then there's some unknowns, but roughly 50% of women with ovarian cancer, the ovarian cancer through one mechanism or another can't fix its DNA well. And so these are susceptible to PARP inhibitors. And BRCA is the key one. In triple negative breast cancer, you'd find germline BRCA mutations in about 10% of patients, mainly HER2 negative. You can find them in HER2 positive, but predominantly in HER2 negative. And now we have new indications for PARP inhibitors in breast cancer, and I'll show you that. And so when you have patients who have metastatic triple negative breast cancer, they get chemo. If they're hormone receptor positive, HER2 negative, which is the population we're talking about, they get endocrine-based therapy followed by chemotherapy. But now that we are testing for BRCA more routinely, it didn't used to inform therapy, but prior to 2018. But after 2018, it does in HER2 positive, in hormone receptor positive, HER2 negative tumors. And so this is important as well. And so we have 4 PARP inhibitors that are approved in a variety of settings, mainly in ovary, some in breast, now in prostate, very recent. So we don't have long-term data on prostate yet, and maybe coming in pancreas. So across the board, we're going to be increasing the use of these PARP inhibitors, which damage DNA, which is really good because they work really well, as I'm going to show you, but do they increase our risk of treatment-related myeloid neoplasms? That's the question. So why are we excited? Like, why use them at all if you think they might increase the risk? Well, they work really well. So this is SOLO-1. I led SOLO-1, which incorporated PARP inhibitors into the treatment of frontline ovarian cancer. So women with BRCA-associated cancers got chemo. Most of the time, the frontline chemo works really well. They're not cured, but it works really well. And then we would wait for recurrences, which happened in 80% of patients. Here, we added olaparib as a maintenance for 2 years versus placebo. And this is what happened. They had at 3 years, about 60% of patients who got olaparib are disease-free as compared to only 27% for placebo. And I can tell you now that we've followed them for 5 years, it's over half of patients still remain disease-free, and we hope some of those women are cured. So this is an unprecedented improvement in progression-free survival, and we hope overall survival. Speaking of overall survival, when we use olaparib in ovarian cancer in the recurrent setting, in patients who respond to chemo, where again, we used to stop and just watch them till they grew back, now we add in olaparib in BRCA-associated cancers. When we look at overall survival, there's an advantage over a year. And so we do have these tremendous responses that are exciting. In breast cancer, it's been tested in a lot of settings, but the indications right now are in hormone receptor positive, HER2 negative, breast cancer that's recurrent, so it's in the treatment setting, and they used olaparib versus physician's choice, appropriate physician's choice, and the progression-free survival was positive, meaning how long do you go until the next recurrence? And it was positive, not landmark like in ovary, but it was positive. But in this group of patients who had no prior chemo, like they may have just had anti-hormonal therapy, they did remarkably well. So there's a lot of excitement there. And then just to be fair, I'm going to show the talazoparib data, which I don't have overall survival advantage for, but also progression-free survival, and it's approved. So when we look at what happens with treatment-related myeloid neoplasms after treatment with PARP inhibitors in these BRCA-associated cancers that have enough follow-up, so that's what I'm showing you here, what you can see is the rates are pretty low, but they're there. And so for SOLO-1, when you use PARP in the front line, it's 1.2%, and they occurred between 15 months and 2 years of duration of therapy. So pretty early when you're considering they only had 1 prior line of chemo, their frontline chemo, and then 2 years later we have an AML. That worries you a little, but it's only 1%, so we kind of say risk benefit. In SOLO-2, which has an overall survival advantage, it's 8% versus 4% in the group that got placebo. But the group that got placebo probably got a PARP later because it's indicated. The difference here in the 4 versus 8 is all the cases that arose after the patients discontinued the PARP. And the PARP is given until progression, so they could have been on it for years. And so we have a lot to learn here yet about what really led to this increase. You know, if you're alive for over a year more, you're going to get more therapy. So is it just reflective of more therapy and more opportunity to be diagnosed, or is there really an increased risk here? You have to take this a little bit with a grain of salt, but we are looking at this and trying to figure out if this is real and who's at risk. And so when we have patients on PARP inhibitors, we make sure that patients know the risk as much as we know it. If there's any kind of delays in recovery of hematologic parameters, we do early referrals to our hematologic colleagues, bone marrow biopsies, and we're watching, they may not have treatment-related AML or MDS, but there's this sort of cytopenia that develops where they don't meet any diagnosis, but their platelets are always 80. So we're watching this to see how often this happens. Again, risk, benefit, the benefit would seem to favor use of PARP, but we really need to pay attention to the downside for our patients to make sure we're doing the safest thing possible. And with that, I think I'm out of time, but I thank you for your attention. And I don't know if I have time for questions, but I'm happy to answer them.
Thank you so much, Dr. Moore, for the informative presentation. We do have a couple of questions. Our first question is, does taking estrogen blockers such as tamoxifen or Arimidex increase a woman's chance of developing MDS or AML?
Not that we have seen at all.
Okay.
Yeah,
Thank you.
no association in any, and I think I read every association paper for this talk, and I don't see any association with that.
Perfect. Thank you so much. For when women are going to begin chemotherapy for a initial diagnosis of cancer, are there any questions that you should suggest that they ask that may be helpful in determining what their risk is of developing a secondary cancer? Are there some specific questions that would be helpful so they can better understand what their risk is of developing a secondary cancer?
Yeah, that's a great question. There's really not, other than sort of obvious things. If someone has, like I take care of women with ovarian cancer who may have a BRCA mutation. They may have had a history of a breast cancer 10 or 15 years before and had a whole slew of chemotherapy for that, and now I'm going to treat them again, and they have a BRCA mutation. Those are kind of a bunch of things that probably do increase the risk for her. And we think about it. We do think about it. The issue is that, what do you do about it? Do I change what I think is the best care for her because of a 2% risk? And I think that's where it gets hard. So I think a complete history, really making sure that we know any kind of history of prior cancer treatment, prior radiation, especially childhood malignancies where they may have gotten radiation for. I have a few patients like that forgot to tell me about their sarcoma when they were 6. So that's important for us to know, and we kind of keep it in the back of our minds, but it doesn't really impact the decisions we make because the risk is still so low at this point.
Thank you. Well, we are after 5 o'clock, so thank you so much for sharing your time and your expertise with all of us today. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to a question or you'd like to send us one at a later time, please feel free to do so by sending an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or you can also submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure disease. The AAMDS-IF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program. Thank you again, Dr. Moore.
Thank you.